Welcome back to everyone in our audience. We are absolutely thrilled to have leaders here with us virtually from Kaiser Permanente, Southern California, and the Permanente Medical Group. We're so excited because their accomplishment led to our selecting them as a co-third place winning team in our Innovator Awards program this year. And I can't wait to have them share with you what they've done. So to begin with, I'm going to ask each of our panelists to introduce himself, his title, and his role, and then we'll get into the subject matter. Dr. Nguyen, would you like to begin?
Great, thank you, Mark, and hi, everyone. My name is Dan Nguyen. I am one of the regional assistant medical directors for the Southern California Permanente Medical Group, Kaiser Permanente. And I lead much of the home care space efforts for Southern California, as well as being the regional hospitalist chief for Southern Cal.
Wonderful. Dr. Cajado, why don't you go next?
Hi, good afternoon, everyone. My first name is Earl. My last name is Quijada. I'm a hospice and palliative care physician by training. And my general thesis has been that care at home is qualitatively better for people. And I've been involved in a variety of projects to move care into the home with Kaiser Permanente, being a COVID home monitoring program being one of them. So I'm grateful to be here this afternoon.
Thank you, Dr. Quijada. Robert Grover.
Hi, Robert Grover. Hello, everyone. I am the Clinical Operations Director of the Integrated Care Center, which is an omni-channel contact center that manages not only KP Southern California Home Health, but also long-term care and a few primary care divisions in the Valley region. It's a pleasure.
Absolutely. Thank you. And you are a clinician by background also.
Correct, registered nurse, yes.
Yes, thank you very much. So I'm going to have you, Dr. Nguyen, begin. Tell us a little bit of the origin story of the clinical home monitoring program as it first emerged and then became much bigger in terms of your overall hospital at home aspirations at Southern California, Kaiser.
Great, thank you for that, Mark. So, if you all recall, way back in the early pandemic, I think the whole world watched in horror as we saw healthcare systems around the world being overwhelmed by the emergence of COVID. We first started in China, and then Italy, if you recall, the system was just overwhelmed. And then it was the States, right? New Orleans, and who could forget New York City? And we knew that California ultimately will face that same scenario. And so we had to prepare. In fact, when we looked at our predictive analytics, it was daunting. The numbers would have overwhelmed our hospitals in the thousands, and we're talking ICU patients. And so we had to quickly pull our teams together and think about how do we help our hospitals? How do we help decant the COVID burden for our hospitals, create capacity, at the same time provide the much needed for our patients who may be recovering from COVID at home. And so a team was assembled. We could quickly pull in our experts, our pulmonologists, infectious disease, our hospitalists, our home cares, physicians and nursing, and really, looked at creating guidelines based on the clinical evidence that we knew at the time. And we were still learning quite a bit, but we did learn quite a number of things about the clinical course of the disease. And so much of our program was based on that in the early days of this. And within a matter of weeks, we came up with the COVID home monitoring program. And we can talk into details about that. But within 4 to 5 weeks, we were ready to pilot within our first medical center. And in a matter of months, we had scaled that really across Southern California and Kaiser Permanente.
Wonderful. And maybe I'll turn to you next, Dr. Quijada. If you could share with us, as you and all your colleagues, Dr. Nguyen and Robert Grover and everyone, started thinking about this, I know that one of the key things that you decided to do, of course, was to determine who might be the ideal patients to be placed in this program. And I'm sure I'm saying this in a wrong way as a layperson, but essentially you were looking for people who had illness, obviously, but were not, at an ICU level where they absolutely needed to be in a facility. If you can explain that in your words, tell us a little bit about the patient profiles that you were looking at and where you kind of landed as you developed the program.
Sure, that's a really good question. So as this program developed, we had some learnings from previous pilots of developing hospital at home type programs. And one thing that we learned from our prior pilots was that clinical criteria matter, and it matters a lot. And it's important to choose the right person, the right patient for these type of programs. So when we were looking at what was happening in China and New York and Italy, as Dr. Nguyen mentioned, we knew that about 20% of patients with COVID would get admitted to the hospital.
Yeah.
Obviously, we didn't want to take all of those 20% patients onto our COVID home monitoring. But if you look at those 20%, they'll be stratified into the sickest of the sick of the 20% and the less of the sick of the 20%. What we wanted to do was we wanted to choose of the hospitalized type patients, choose the 20 to 30% who would be on the lower end of acuity of those hospitalized. So, there's several barriers to this. One, we wanted to make sure that we were providing safe care, first and foremost, safe care. Two, we wanted to help the hospital system. Three, we wanted to save lives. So in determining who these 20% were going to be, we looked at the stuff that came from China, and we knew right away that there were going to be, we were shocked that old meant 50 years old. So, initially we're saying, well, maybe the 70-year-old patient, we're like, no, that's too old. So we first aimed for these, for the younger set, these 50-year-old type of patients with maybe one or two medical comorbidities. And we did not want them hypoxic right away. There's two ways to look at this program when we built it out. One was to look at it on the front end as a triage patient to escalate into the hospital care later on as the disease progressed, and two, to look at it as a recovery type of situation. So we set things up for both ends, but we really wanted to get those patients where we could triage, where we could choose the right patient and escalate them as necessary in a safe, effective manner, but also to give everybody some space, saying, hey, not everybody has to go into the hospital. So we first started off with a very conservative group, one or two medical comorbidities, not too hypoxic, and maybe this 50-year-old age. We didn't want to get the complicated 70, 80-year-old patient. So that's who we initially went for.
And as you developed the program, pardon me, I'll ask all three of you, what were your broadest strategies? What were you hoping to accomplish? And whoever would like to begin.
I'll kick it off, and then Dr. Quijada and Bob, please chime in. But to Dr. Quijada's point earlier, Mark, we wanted to create a program that will enable us to create an alternative to hospitalization, right? We want to identify the right patients for this program. We don't want too high risk, and we don't want too low risk either, but we want to be able to offload the hospital as an alternative. But the program needed to be safe and reliable, and be able to help physicians and the healthcare team quickly identify a risk of deterioration, signs and symptoms of deterioration at home, so that we can intervene. And so that was an important part of our goal in creating this program. And that's why when you look at the core elements of our program, it was built around that. What was the COVID home monitoring program? It was a program that was staffed by physicians, nurses, and healthcare team 24/7. We had the ability to touch patients daily. We had the ability to escalate and resolve a patient's need timely 24/7, and that includes physicians. And then we had the ability to remote monitor these patients. All these patients were discharged to home with what we call a COVID kit, which includes a thermometer, a pulse ox, so that we can monitor the oxygenation, which was one of the big concerns as these patients go home and they can deteriorate and become hypoxic. So the pulse oximeter was very important. And then it helped to monitor the heart rate. We also had a software platform that enables communication between the patient and our healthcare team, as well as the ability for video conferencing with our healthcare team. So the program with all these elements was meant to create a safe, reliable program that helped our healthcare team provide a safety net and manage the care for our patient to our home.
Absolutely. And as you initially saw success, of course, which was great. And as you saw that success, what operational elements, Bob, if I could turn to you to talk about some of the operational elements of managing patient flow or traffic, whatever term one would want to use. And I know you were very deeply involved in that and still are. Tell us a little bit about some of those practical operational aspects.
Sure. I mean, to piggyback off of what Dr. Nguyen just said, is the ability to see O2 saturations remotely in near real time allowed us to, triage at even a deeper level than we otherwise would. And this is the real-time data coming in where we could see 10 alerts come in, say, over a 15-minute period, and looking and seeing that some alerts had an oxygen saturation of 98% versus others that may have been at 82%, allowed the nursing team to prioritize in real time to help those who needed the help quickest. While it's not like the people with 98 aren't important, but when someone's oxygen saturation is in the mid to low 80s, they're truly in trouble. And you could take steps that could be managed within the home, or you can identify life-saving efforts to get somebody to the ER as quick as possible. So as the pandemic and the process evolved, we were able to actually fine-tune our protocols almost on a month-by-month basis to adjust to make sure that we were getting to the sickest of the sick as fast as possible. My vision for the contact center was pretty much the end-to-end glue that held everything together, from the discharge planning point of view, from the hospital perspective, getting them onto the programming, all the way through the discharging from the program. The team is both nursing and administrative, and there were key roles in both of those subsets of staff when it came to the processes that we did. But it was basically a just under fire, essentially, the whole time, particularly in the winter surge, and again, more recently in the Delta surge.
What have been the biggest challenges that you and your team have faced operationally?
Just the again, not having a long history where we could show precedent that we can align our staff over predictable hours when we know alert traffic is going to come in. We've had to adjust our operational model during the pandemic and just reconfigure the way we work. You think nursing is traditional 8 hours. Well, we realized early on in this pandemic that really wasn't going to work. We needed to think in 4-hour shifts, double and triple up on nursing between, say, 5 p.m. and 9 p.m., because it seems that's when most of the alerts are coming in. So it's examples like that. I mean, you couldn't go in with a historical model and expect to be successful. So that was one of the largest things that we determined needed to change quickly, and the team adjusted fast.
Yeah, absolutely. So now, doctors, tell me, one of the things that we found fascinating is, as you establish this program and you quickly realized this could have good long-term staying power through and beyond the pandemic as a hospital at home program. As clinicians, what have you learned, and what has been particularly successful as you've brought this to a greater scale and moved it toward permanentization?
Dr. Quijada, you want to take a stab at that?
Yeah, so the things that we learned doing this COVID home monitoring program that could lead to the hospital at home are several things. One, care coordination matters. It matters a lot. And the things that we learned from this program, and when I talk about care coordination, the first piece of care coordination is adherence. Because without the adherence piece, none of this stuff really works. So we built a lot of a safety net into this idea about adherence. So the thing we learned a lot was that when patients go home with technology and kits and who are quite ill, there's a lot of confusion that happens. They're scared. They don't know what to do with the equipment. And because we were able to have a centralized model of enrollment, this helped with getting just the basics done right away, to getting the patients to know how to at least turn on their machine, download the app, and use the equipment. So that's important. The other thing that we found really important is this idea about adherence and this idea about nudging. So on our first pilot, we had about maybe 50-60% adherence to the technology, adherence to the technology. That's not enough. But we added a layer because of the integrated care center, because of our centralized model, we had a layer of nudgers, and that brought up our adherence to 90%. So that's a big learning, that nudging matters and design matters.
Yeah.
Obviously, we'd like to get to the point where we don't have to use as much manual nudging with proper human-centered design, but that nudging piece was super important. And I'll pause right there and see what Dr. Nguyen has to add.
And if either of you want to add any just high-level metrics or statistics.
Yeah, Mark, I just want to add to your question earlier from a high level standpoint. We're very early on in the whole acute care at home journey right now across our nation, right? The whole healthcare system is in this early stage of trying to adopt hospital at home. And what this COVID home monitoring began to taught us, 17,000 patients later, we've enrolled into this program. It has built great confidence for our healthcare teams, our physicians, that we as a healthcare system can safely and reliably deliver care for patients at home, and very high acuity for that matter. Because that has been the biggest barrier, not just within Kaiser Permanente, but really across the country. Physicians simply are conservative, we're concerned about safety. And so we tend to keep patients in the hospital for the most part, unless they're absolutely stable to go home. But this program really helped us see that, no, we can actually manage these patients virtually at home. We can actually use remote patient monitoring, which is a new thing also for us. Remote patient monitoring technology can absolutely enhance care. And so that was a big learning for us. Actually, how do we actually utilize remote monitoring and how do we know the right triggers, right? That was a learning for us. Is it 98%? Is it 92%? So we learned that, and we kind of refined that as we went through this. And so that was a big deal for us. And then, so I think that the most important thing, though, to your question earlier, is this program helped us validate the hospital at home program, that it really is a legitimate model of care, that we can deliver high acuity patients and deliver their care in the comfort of their own homes if we have all the bells and whistles in place. So I think those are the sort of the high level learnings as the healthcare system across the US matures, and as groups began to think about how do they actually implement. I think this will give them some assurance and confidence that we can absolutely do it.
Yeah. Dr. Quijada, what would you like to add to that?
Yeah, I'd like to double down on that the one thing we learned was this program was safe. When we look at our analytics, our quality analytics, our quality metrics, our mortality, when we compare groups to groups, was no different. The sick groups at home, the mortality was no different than the sick groups in the hospital, similar sick groups in the hospital, the mortality was the same. So we know that this was not a lower quality of care. Two, we know that we were able to save hospital days. When we look at a subset of a population that otherwise would have been hospital, when we compare group A to group B that otherwise would have been hospitalized, we saw that with the COVID home monitoring as a safety net and to deliver novel ways of giving therapies at home, we could decrease hospital days from 5 days to basically 2.5 days. I'm rounding right now, but that was a significant difference.
Yeah.
And we also learned that patients love it, that patients felt safe, patients felt connected, and they felt like they weren't being left alone. And with such a scary disease, to have a patient feel like someone's watching them and they felt confidence in the team monitoring them was a huge deal. So we know that it was safe, it was effective, and the patients really, really liked it.
Wonderful. And all three panelists, share with us what you think are the absolute essential critical success factors. Those can be people, process, technology, anything. Key elements that anyone who wants to try this must be able to achieve over time.
Bob, you want to take a crack at
Yeah,
it?
Bob, why don't you start?
So from process technology, you have to have lean processes. You have to have integration. You have to think outside of the box in terms of communication inbound. Inbound phone calls, in my opinion, are going the way of the dinosaur. Basically, you need to think of different ways to communicate into a call center other than picking up a phone and dialing. You can't scale that because whenever you're doing a phone, you have to have someone on the other end. Electronic communications made this incredibly scalable rapidly. So that's my takeaway. Just lean processes, integrated, and leveraging the correct technology to bring everything together. And then the final cherry on top is adding automation where you can over the administrative side to take care of things like reporting, outbound nudging. That's my takeaway here from a process standpoint. I feel like we're at the tip of the iceberg and it's only going to become more efficient over the next few years.
Great. Doctors?
I'll just add a few more, Mark. I think the design absolutely is key, and bringing in the right stakeholders, right? This team, the care and the management of this program required so many disciplines. And so you absolutely have to bring in the teams, make sure people feel like they're part of this, all the stakeholders are there, and be able to standardize the care. I think that's important for us. We have 4.7 million members across Southern California with 15 medical centers. Imagine if we all did things differently, it'll be very hard to manage. So standardizing your processes as the best you can, standardizing your clinical guidelines and management of how you manage patients is the utmost important as well. And we put in a lot of effort around that. We mentioned already the coordination of care between team is so critical. And then last, I'll mention that, because of the population that we're managing, how rapidly the clinical situation can change, can deteriorate, having the ability for 24/7 clinical escalation and oversight is so important. And I think it would be extremely challenging to have a program as such without that clinical oversight. So, Dr. Quijada?
Yeah. One thing that was key to the success in this program, as we were learning about this disease and as treatment protocols were changing and as staffing ratios were changing, as we learned how to ebb and flow with surges and numbers, was that we used data to guide us. And we used it in a significant way. So we were able to use data to relook at what we were doing, iterate, and make the proper move. So to have a robust analytics program when you start with these programs is really it's critical to have an idea of what you're going to look at.
Yeah. Can I ask you all any things that you'd like to say regarding analytics and IT specifically? Any thoughts?
Yeah. So, and I think this is an area that's not a surprise to anybody. right now, but the idea about integration and interoperability is a huge deal. And as I say, come in with a broad data analytics plan. It's harder because of the integration and interoperability issues. You have to have a lot of doubling, tripling, checking, and you have to have a team that's really, really looking in all different ways. We had our vendors' data, we had our own internal data, we had to cross-match, we had to validate, just because the integration and interoperability piece weren't there yet. We were looking at two different systems. But that being said, and it's no secret that that's going to be the key to getting these type of programs scaled and spread is that integration interoperability piece.
Oh, wonderful. Absolutely. So what do the next couple of years look like for this program?
You want to go, Dr. Nguyen?
Yeah, why don't I mentioned earlier, Mark, I mean, I think that the future is so bright for the whole home care landscape. I think what this program has taught us is that, it's one disease that we're managing, but there's so much applications to what we can do with remote patient monitoring, with now the ability to do 24/7 clinical oversight. I think this program, we've already done it. We've through this program, really, it helped us jumpstart our own hospital at home program across Kaiser Permanente. So in fact, the last 12 months, we've scaled our hospital at home program from 1 med center now to 8 medical center.
Yeah.
And so I suspect that will absolutely continue. We will continue to expand our ability to provide high acuity care at home. That program in turn will enable care even beyond acuity, and that's the chronic disease management. That's the more of the aging comorbidity types of patients who really require care and monitoring at home. So it does really help us think through those, and now really helps have built the foundation of how we can begin to think through some of these programs.
Yeah, absolutely. As you consider this, Dr. Quijada, what do you see a continuum also? It sounds like that Dr. Nguyen sees a continuum across from chronic to hospital at home, that there is a bridge there between those two elements.
Yeah, absolutely. Early in my introduction, I stated my thesis that, we're here because we truly believe that care delivery to the home is qualitatively better. And that's going to be whether or not it's acute hospital in the home, chronic care, primary care, and all the different avenues and products that could come. I think we're entering into the most exciting time in medicine, I think, in the last 20 years. And in the next 5 years, like I mentioned, you're going to see a lot more integration and interoperability. That's going to give us treasure troves of data, and not just data, but in the next 5 years or so, we're going to have machine learning and AI that turns that treasure trove of data into insight. And once we get that insight, then we're doing business where we could have a single platform to deliver care. And then from that platform, we could go off into our different lanes, whether or not it's acute care at home, chronic care, and in my field, home-based palliative care, hospice, and a variety of different things. I don't want to say here that that's the only type of care that's going to happen, but there's going to be this big movement there because of the tools that are being developed today, tomorrow, and the years to come. And it's a very exciting time in medicine.
Wonderful. Final advice for those who would follow in your collective footsteps, all three of you.
Well, I'll go. I'm just going to echo what we talked about: interoperability, integration, lean processes, and don't be afraid to think outside of the box. I think we are in a new paradigm here. So think outside of the box.
Absolutely. Dr. Nguyen?
Yeah, no, absolutely. My advice would be, if you're thinking about doing it, if you're thinking about building an acute care at home program, you absolutely should. There's less fear now out there that it's not a valid model. I think the model itself has been validated through multiple examples already. And this is one example that has really given us a lot of confidence. So I think if your medical center, your health group is thinking about it, I say absolutely go for it. I think there are some key elements that needs to be put in place, absolutely, just like anything else. But I think we've validated the model of care. I think high acuity at home is not so far out of reach anymore. It's already being done. We're already doing it. Technology, Mark, where you're from, technology is going to help enable this. It's going to enhance the care. It's going to continue to make us better clinicians and be able to examine patients and manage them from afar. And we're doing that now. And so absolutely go for it. Be bold. And certainly learn from some of the example and the programs out there, including what you've heard today. Thank you.
Dr. Quijada.
So one thing I'd advise for those who haven't tried this is that if you're to start a program like this, focus on one disease with very few variables and build your processes around one disease with few variables to make sure that you got it right. And then with that, take risk. I understand that medicine's a safety net, but a little bit of risk. And there's people who've gone before you. It shows that it's safe. So focus, take that risk, and keep your eyes to the future.
That makes total sense. I want to congratulate all of you because I think this is quite a significant achievement. And you've also been able to demonstrate that it can be very successful if done right. What's interesting to me and my team of editors is as we cover hospital at home across the country, we just see 1,000 flowers blooming, right? Like everyone is kind of doing this in a different way, and that's okay because everyone will learn from each other. Health system A will learn a few things from health system B, will learn a few things from health system C. So I think the next few years are going to be very interesting. You're all right. The technology is enabling a level of clinical intervention in the home that was never possible before. So we're really on the verge of a kind of a different era in healthcare. But I want to congratulate all of you at Kaiser Permanente Southern California and the Southern California Permanente Medical Group in innovating on this, because this is a really important area. It's absolutely leading edge. And I think that over time, we will all collectively learn a great deal. I think we'll be in a very different place 5 years from now than the one we're in. So I want to thank all three of you leaders for being with us today. Again, I want to congratulate you on your accomplishment, and I want to wish you the very best as you go forward. I think the future absolutely is bright for this program and for your organization because of your leadership. Thank you all so much.
Thank you so much, Mark, for inviting us. It's been an honor to be here to share with everyone. Thank you.
Absolutely. We're thrilled. Thank you all very much. This concludes this session, and we look forward to seeing everyone at our next session. This concludes this session. Thank you very much.
Thank you. Take care.